of my UQ colleagues, all of fellows of the Academy, and other guests who are with us here this evening. And it really is a great pleasure to join you. While I think, like all of us, I would have liked to have joined you all in person, in these socially distanced times, we know that that's just not possible. But if there's a silver lining, I think it's that this online format will allow even more people to listen in from both Brisbane and around Australia, and possibly even more broadly. So I was delighted to receive the invitation to be involved in tonight's event. As many of you will know, I started my academic career here in the School of Psychology at UQ some 30 years ago. And I have many fond memories of my years in the school, a time that I think certainly positioned me extremely well for the roles that I've had the privilege to have and to hold since then. So to have the opportunity to be involved with the school and to listen to one of the school's extraordinary early career researchers, Dr. Melissa Day, really is a treat. And what better time to do this than during Social Sciences Week. I think it is a time of the year when we all should pause and do pause to reflect on the importance of the broad social sciences, not only for the future strength of our civic society and our social cohesion, but for the bold, multidisciplinary and focused efforts that will be required if we are going to address the very significant challenges of our time. So in this context, it's very appropriate that we have the opportunity to hear from one of Australia's leading early career social scientists. And this evening, it gives me immense pleasure to introduce Dr. Melissa Day. Melissa is a clinical and a health psychologist, and her main area of research interest is optimising non-pharmacological treatment options for chronic pain. Melissa holds a Bachelor of Science, a Master of Arts and a Doctor of Philosophy, all from the University of Alabama. After completing her doctorate, she undertook a clinical psychology residency at the University of Washington, a postdoctoral research fellowship in pain psychology, followed at the same institution, and then an early career fellowship from the National Health and Medical Research Council on the management of chronic pain brought her here to UQ. She's now licensed as both a clinical psychologist and a health psychologist in Australia, and she's a senior lecturer within the School of Psychology. Melissa's work has been continuously funded since her first clinical trial as a PhD student, which is very impressive. She's been awarded grant funding of more than $350,000 here in Australia and a further $8.6 million in the United States. Her impact is further evident if we have a look at her publishing history. She's published 32 articles on pain management, which have been cited now close to 500 times. And in the area of pain medicine, more than 90% of her articles have been published in the top 10% of journals. So I think we'd all agree it's an absolutely tremendous record. And so without further ado, I'll now turn proceedings over to Dr. Melissa Day to deliver her Paul Bourke lecture. And I think it will be a real treat to hear about her current research and her research plans into the future. Thank you very much, Melissa.
Thank you. I am just having technological difficulties in sharing my slides, but can you all see my slides there now?
That's good, thanks.
Okay, you're welcome. So I too would like to acknowledge the traditional owners and their custodianship of the lands on which we meet today, and pay my respect to their ancestors and their descendants. Professor Deborah Terry, Officer of the Order of Australia, Vice Chancellor and President of UQ, Dr. Chris Heatherly, Chief Executive Officer, Academy of the Social Sciences, UQ colleagues, distinguished guests, ladies and gentlemen. It was an honour to receive the Paul Bourke Award, and it's my pleasure to get to present this lecture and to discuss with you today really the research that my collaborators and I have been doing to advance non-pharmacological treatments for chronic pain. And so just as an overview of what I'll be discussing, I know that we have quite a lot of people from different specialty areas and backgrounds. So I'll start by providing a brief definition of pain, and then I'll shift to the costs of chronic pain. And then most of today's talk, I'll be talking about treatments for chronic pain and the underlying mechanisms for these psychological treatments. And then I'll finish with some needed future directions, some take-home messages, and we'll have plenty of time for questions as well. And so the International Association for the Study of Pain is really the leading international body on clinical research and practice in relation to pain. And IASP defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And so inclusion of the terms unpleasant here and emotional experience, this definition clearly delineates psychology as integral in the experience of both acute and chronic pain. And when we look at chronic pain then, the definitions of chronic pain, that's when pain persists beyond the normal or expected healing time. So this definition works quite well in the context of injuries, traumatic sources of chronic pain, but it doesn't work as well in the context of conditions such as arthritis. And so another commonly used definition of chronic pain is pain that is experienced at least half of the days of the month for the past 3 to 6 months. And chronic pain is it's a massive problem in Australia. So these are statistics from 2018 from Pain Australia. And in 2018, 3.24 million Australians live with chronic pain. And this number is set to rise to 5.23 million by 2050. And this is because here in Australia, we have an ageing population and we also have high rates of obesity. And both of those are risk factors for the development of chronic pain. Further compounding the condition is that almost 50% of individuals also live with depression and symptoms of anxiety. And generally, chronic pain is treated within the GP setting. So 20% of general practitioner visits in Australia involve chronic pain. And of those people who see their GP, actually only 1 in 100 will receive interdisciplinary care. And interdisciplinary care is really the gold standard treatment approach for chronic pain management. And when people do see their GP, typically what they receive is medications. So 70% of GP consultations for chronic pain management involve medications. And so this amounts to massive financial costs to the economy. So $139.3 billion was due to chronic pain in 2018. And as you can see from this slide here, this includes direct healthcare costs as well as indirect costs associated with lost productivity. And as you saw from the previous slide, interdisciplinary care is really the gold standard, but it's really only received by 1 out of 100 Australians. Most people are actually given pain medications, and all of this combined actually in the United States actually led to what was called the opioid epidemic by the Centers for Disease Control. And here in Australia, we have a similar situation. So in 2016 to 17, over 15 million opioid prescriptions were given. and the death rates for opioid poisoning actually rose by 62%. This is in the face of guidelines put forth by the CDC and other leading bodies that really non-opioid therapy should be the first-line treatment approach for chronic pain management. And one thing we know from a great body of research over the last, really the last 40 years, is that non-pharmacological psychological treatments actually routinely get similar effect sizes to opioids. So opioids for chronic pain tend to result in about a 30% reduction in pain intensity, and we do routinely get those effect sizes with psychological treatments. So while really the frontline treatment approach for chronic pain has still and continues to be biomedical in nature, these psychological interventions have evolved that are at least as effective as medication and surgery. And so the leading evidence-based psychological treatments, behavioural therapy, cognitive behavioural therapy, and more recently the evidence is building for mindfulness-based interventions and acceptance-based interventions. And I'll be presenting mostly data on cognitive behavioural and mindfulness-based interventions today. So even though the evidence on the efficacy of these interventions has been coming in for the last 40 years, what we see when two or more of these treatments are compared is that we tend to see more similarities than differences in outcomes. This is perhaps the most widely replicated finding in psychology. It's been referred to as the Dodo bird verdict. All shall win and all must have prizes because, again, when you compare two evidence-based treatments, both treatments tend to improve pain outcomes to approximately similar degrees. The other concern, though, is that effect sizes on average tend to be modest. And this is because there's a great deal of individual variability in treatment response. And so within cognitive behavioural therapy, for example, some people will achieve a great deal of benefit from CBT, whereas other people will not benefit as much from that. And so in randomised controlled trials, when we look at efficacy, the results of those two individuals, of course, across a whole massive sample gets averaged. And that's why we tend to see these modest effect sizes from efficacy studies. So to address this, really in the past decade, there's been a shift from this first order question of do psychological treatments work to really understanding how do psychological treatments work. So this has really been a central focus in the field. And this is not just a theoretical question either. I will delve into a little bit of theory today, but there's really important clinical implications that arise from answering this question. When we know how our treatments work, we can distill down the active ingredients of these treatments so that we can then more effectively engender shifts in mechanisms and make them more streamlined and efficient. And we can also begin to target synergistic effects to shift multiple mechanisms as well, which should increase efficacy and boost effect sizes. The other thing that we can learn from addressing this question is that if different treatments, so if mindfulness treatments, for example, versus cognitive behavioural treatments, if they have been shown to work via different mechanisms, then that means that different people are likely to benefit from those treatments, and this will eventually inform precision medicine. So these are just a few of the real world applications that pertain to this question. So it's not just theoretical, but theory certainly helps inform the direction of research to build a coherent base of evidence. My collaborators and I, we actually recently tested some of these mechanism questions in the context of a randomised controlled trial. And this research was recently published within the Clinical Journal of Pain. And in this study, we implemented a pilot randomised controlled trial, and we compared the efficacy of cognitive therapy, mindfulness meditation, and mindfulness-based cognitive therapy. And the sample was adults with chronic low back pain. And the mechanisms that we tested were pain catastrophizing and mindfulness. So pain catastrophizing is really defined as a negative mental set about actual or potential or anticipated pain. So thoughts like this pain is terrible, it's never going to get any better. That's an example of a catastrophizing cognition. Whereas mindfulness is defined simply by paying attention on purpose in the present moment with a non-judgmental attitude. And so based on the theory of the respective psychological treatments that we tested in this study, we anticipated, or we hypothesized, that those treatments that contained a cognitive therapy element that were designed or intended to address maladaptive cognitions, so cognitive therapy and mindfulness-based cognitive therapy, that these would shift pain catastrophizing, and that pain catastrophizing would be a stronger mechanism in those two treatments relative to mindfulness meditation alone. In terms of mindfulness, we expected mindful observing to be a mechanism only in those treatments that targeted it. So that's with the mindfulness meditation condition and the integrated MBCT protocol. And we tested the changes in these mechanisms in relation to changes in our primary outcome, which was pain interference. So in terms of the key findings for a primary outcome with pain interference, we found significant reductions in pain interference from pre to post treatment in mindfulness cognitive therapy and mindfulness-based cognitive therapy. And these are actually large effect size reductions. And as has been well established in prior literature, we found that, that when we compared the active treatments, there was no differences between treatments in improvement, but all three treatments did effectively engender reductions in pain interference. So then when we look at the findings for the mechanism of pain catastrophizing, we found significant improvement in pain catastrophizing from pre to post treatment. And between groups, we again found more similarities than differences. So there are no differences in improvement in pain catastrophizing across the three treatments. All three treatments significantly improved the mechanism of pain catastrophizing. Similarly, with mindfulness, mindful observing, we again got significant improvement from pre to post treatment in this mechanism. And between groups, again, we got similar improvements in mindful observing, which is not as we expected. So this means we have similar improvements in outcome, similar improvements in the mechanism variables, but the real question of interest is whether these changes in mechanism differentially operate to predict outcome changes as a function of the different treatment conditions. And so when we look at the mechanism to outcome links, we found a non-significant interaction effect between pain catastrophizing and treatment on pain interference. So this means that the interaction between treatment condition and changes in pain catastrophizing did not significantly predict changes in the outcome. However, we did find a significant main effect of pain catastrophizing. So this means across all three treatment conditions, improvements or decreases in pain catastrophizing predicted decreases in pain interference. And that's across all three treatments. When we look at the mechanism outcome links with mindful observing, the interaction was non-significant here, and across conditions, mindfulness was not associated with outcome. So to summarize these findings, really this trial showed no differences in the degree to which these three treatments improved outcomes, and no differences in the degree to which they shifted the mechanism variables that we tested. So this really suggests that change in pain catastrophizing may not be unique to treatments that contain cognitive therapy elements, and changes in mindfulness might not also be unique to treatments that include mindfulness meditation. The results do also suggest the potential that pain catastrophizing really might play a stronger mechanism role across unique treatments than changes in mindful observing. And when we combine these findings with findings from other literature, it raises the question of whether pain catastrophizing is actually a meta-mechanism that really accounts for outcome improvement across a range of different treatments with unique theoretical bases. And so if we look at some of this other literature here, we way back in the day when I was a graduate student and worked with Dr. Beverly Thorne, we were running a randomized controlled trial back then, and that trial was comparing cognitive behavioural therapy versus pain education in low literacy minorities in the US. And what we found there is that both CBT and pain education significantly improved pain outcomes, and pain catastrophizing actually predicted that pain outcome improvement across both conditions. But when we look at even other research, if we look at CBT versus physical therapy, this was a trial done by Smeets and colleagues. What we find here is that pain catastrophizing also predicted pain outcomes. So this is where cognitive behavioural therapy explicitly targets these changes in maladaptive cognitions. And here we find physical therapy that really is more of a manipulative body type of technique. This also actually reduces pain catastrophizing and is associated with improved pain outcomes. But it's not just self-report outcomes. This is perhaps one of my favourite studies by Semenowitz and colleagues. And they looked at neuromodulatory changes and found that CBT actually increased grey matter in regions that are important for pain processing. And this was actually predicted by reductions in pain catastrophizing. So really the tempting conclusion when you take all of this literature combined plus other studies is that all effective treatments tend to engender about the same amount of improvement in pain outcomes, and they tend to do so via the shared pathway of pain catastrophizing. I'll try not to digress too much, but one thing I will point out, one of the reasons I love this study is that oftentimes people with chronic pain come to me and they are concerned about being referred to a psychologist, that might mean that their pain is all in their head and that their pain is not real. Psychological treatments work for real chronic pain, and they even increase brain volume. I think this is just a clear indication of how mechanism type of research can reduce stigma and hopefully increase uptake for these evidence-based treatments. However, returning back to this idea that pain catastrophizing might be this meta-mechanism that improves pain outcomes across treatments and even might be responsible for increasing grey matter volume, there are some concerns or limitations, I suppose might be a better word, for how we reach this conclusion. Just as in efficacy research, there is also the lumping problem in mechanism research. And so what I mean by the lumping problem is that we randomise people to groups and then we look at these group averages. So we lump all types of different people with all kinds of unique aspects in their pain processing. And then of these people, what's the average process by which some people get better and some people might actually get worse. It's likely, however, that really the mechanism pathways really differ between people who are well matched to a certain treatment, so they are treatment responders and they get meaningful benefit, versus those people that are not particularly well matched to that treatment and they're actually non-responders. It's very likely that the mechanisms for those different individuals are quite unique. And so really tests of moderated mediation will afford a much more nuanced understanding of these processes for different individuals. And so if we come back to this second order question, so we are starting to look at how do treatments work, and the other critical question is also for whom do treatments work. And to date, there's really been a lack of theory-driven moderation research in the area of non-pharmacological treatments for chronic pain management. To date, most of it has been post hoc. So we will run randomized controlled trials, and then we'll examine things like baseline demographic characteristics and whether those might predict outcome improvement. Certainly that body of research has made tremendous advancements and contributions to the literature, and using a theory-driven approach really can help us to determine a priori how to match people to different treatments in order for them to be optimally beneficial. And so to really start this work, it's not to say that our model is at all the final model, but we proposed an initial model for this, which was the limit, activate, and enhance model, which provides a means to match people to different treatments. So this is an overly complicated slide, and believe it or not, is actually a simplified version of the overall model. But this model includes how to match people with different patient profiles at baseline, while also considering contextual factors like low motivation or low treatment expectancies. Also the need for potential preparatory interventions. So perhaps there's a need for an antidepressant, for example, to bring down levels of depression so that someone can appropriately engage in intervention. But if we take a more simplified look at this model, and if we just pick one patient profile here, if we look at a limit profile, what this model basically in essence says that here, if we have an individual that has a high degree of pain catastrophizing, so a high degree of maladaptive cognitions, theoretically a well-matched treatment for that particular individual will be one that explicitly targets that pain catastrophizing. So that would be cognitive therapy, for example. And when that person with high degrees of catastrophizing engages in this cognitive restructuring treatment, pain catastrophizing should lower, and then we would get decreased pain interference. If somebody doesn't have a high degree of pain catastrophizing to begin with, really we would question, why would we deliver a treatment that targets that? It's not a problem for them. Perhaps though they happen to be a couch potato and they need increased uptime, they need increased activation, and maybe they need a behavioural activation protocol. What this model also suggests though is that people with a specific deficit really might not need the kitchen sink thrown at them with an integrated cognitive behavioural therapy program. So it will actually be more cost efficient as well if we can more appropriately match people to the skills that they need to achieve meaningful benefits in outcome. And we conducted initial tests of this model using the data from the randomised controlled trial that I was describing earlier. And this paper was published earlier this year in the Journal of Pain. Just as a bit of background to define what I mean by a moderator variable is a baseline characteristic, so a presenting patient characteristic that interacts with treatment to affect outcomes. That is that the treatment effect really depends on the value of the moderator or the presenting patient characteristic which precedes treatment and is not associated with treatment. In this particular study, the moderators that we tested based on our theoretical framework were pain catastrophizing. This is because the component of our model theorizes that treatments for cognitive techniques that are really aimed towards reducing these maladaptive cognitions should be most effective for those people that have high levels to begin with. So high baseline catastrophizing was hypothesized as a moderator for cognitive therapy and mindfulness-based cognitive therapy relative to mindfulness meditation alone. We also looked at resting state EEG, And our model really theorises that the treatments that are designed to activate adaptive responses are best suited to those people who have low levels of those adaptive responses that are being targeted for increases. So in terms of EEG measures, these slow wave oscillations of theta and alpha, these reflect a focused yet calm, relaxed brain state that we hypothesised, or that has been shown in past research, that is cultivated with meditation. And one of our prior studies also showed that people with low levels of baseline theta and alpha that might be in need of activation responded best to a meditation condition. So we hypothesised that those people with low levels of theta and alpha might respond best to mindfulness meditation and mindfulness-based cognitive therapy relative to cognitive therapy. Finally, the enhanced component of our theoretical model suggests that those treatments that are designed to capitalise on strengths are best suited to those who have high baseline levels of those strengths. So given that mindfulness meditation, mindfulness-based cognitive therapy, it's designed to really build on that inherent capacity to pay attention and observe experience in a non-reactive manner, we hypothesised that a baseline strength in this would be a moderator in mindfulness meditation and mindfulness-based cognitive therapy. And so what we found in terms of the limit moderator of pain catastrophizing, we did find a significant interaction effect for mindfulness meditation versus MBCT. Those people that were high in baseline catastrophizing, actually that predicted less improvement if they were randomized to MBCT. So this suggests that high pain catastrophizing might actually interfere with treatment in MBCT and might be a vulnerability factor. However, in mindfulness meditation, the higher that people's catastrophizing was at baseline, the more improvement that they got on pain intensity. And you can see they're basically a flat line with cognitive therapy, where pain catastrophizing at baseline really didn't have much of an effect on improvement in cognitive therapy in relation to pain intensity. We also found a significant interaction effect for theta power in cognitive therapy versus mindfulness-based cognitive therapy. So in the MBCT group, actually more theta at baseline was associated with greater improvement in depression, whereas theta appeared to interfere with response to cognitive therapy. So even though this wasn't exactly in line with our hypotheses, this suggests that those people with a relaxed yet focused brain state, so they have high theta, they were able to build on this strength with MBCT to improve outcome. And this is consistent with some research that has shown that high levels of theta make people more conducive to readily enter into a meditative state. If we look at mindful and non-reactivity, we also found a significant interaction effect between mindfulness meditation and mindfulness-based cognitive therapy. So in MBCT, what you can see here is that those people who were had high levels of mindfulness at baseline, this was associated with greater improvement in physical function. So this was consistent with our conceptualization of MBCT, enhancing or building upon this baseline strength to improve outcome. Whereas interestingly, in mindfulness meditation, higher levels of baseline mindfulness actually interfered with response. And so to summarize these findings then, high pain catastrophizing at baseline, these people who have this might benefit the most from mindfulness meditation, whereas those who have low pain catastrophizing and or high mindfulness at baseline might respond best to MBCT. The pain catastrophizing findings in this study, though, need to be interpreted with some caution, as the measure we used, the pain catastrophizing scale, was low in this sample and was significantly lower in cognitive therapy than the other two conditions. So really we need future research to replicate this to see really the role of baseline catastrophizing, particularly in relation to cognitive therapy. The EEG findings suggest that different brains, so to speak, might be more or less suited to different treatments. So we found high theta power those people responded best to MBCT, whereas it interfered with response to cognitive therapy. But certainly these results provide proof of principle that really these baseline moderators that are selected based on theory really do have the capacity to identify different people responding to different treatments. There's a number of needed future research directions here. Certainly there are some measurement issues, so measures of unique constructs that are used in randomized controlled trials are often highly correlated, or perhaps they actually use reverse scoring, and it's not clear that reverse score distractibility, for example, is the same as mindfulness. So certainly advancement in measurement is needed. We also need to isolate and identify the role of common factors. So this is things like therapeutic working alliance, group cohesion, placebo effects, expectancy. Perhaps these might be really a necessary, but maybe not sufficient foundation for change. And then also research factors. We can actually only prove, so to speak, what we test. And so the information that patients provide to us is really constrained by what measures we use. And this is a study that was conducted by my master's student, Brittany Catnash, that looked at first-person qualitative interviews and accounts to look at the themes presented by patients. And at the end of treatment, what you can see here, if we zoom in on just MBCT, you can see that there's common factors at work, there's emotion regulation processes, attention processes, cognitive processes, behavioural processes. So really these first-person patient accounts really highlight the nuanced processes potentially underlying shifts and change during mindfulness meditation, cognitive therapy, and mindfulness-based cognitive therapy. So the future question that's really in need of answering is what treatment by whom is most effective for this individual with that specific problem, under which set of circumstances, and how does it come about? Maybe slightly dismayed to see the date with this quote. And we haven't answered this question entirely yet, but we have made tremendous advancements. Psychological treatments have now been developed and effectively applied for chronic pain management. We're moving beyond the question of does it work to looking at how does it work and for whom does it work. And really these knowledge of treatment mediators, this will lead to targeted, streamlined, cost-effective treatment protocols. And advancing our understanding of moderators will inform patient treatment matching algorithms. Just to conclude, I'd like to thank my collaborators. This work, even though it's only me here presenting, it's a massive team effort, and I am really privileged to get to work with wonderful collaborators that just bring so much joy into my job, that make me really, really lucky to get to do this work. And also just to say that this research was supported by the Australian government and the University of Queensland. And this was the beach that I was at a couple of weeks ago with my little puppy, my French bulldog Yoda, and I thank you for your attention, and I welcome questions and comments.
Thank you, Melissa. That was an absolutely fascinating presentation, and the beach, Torian, that was, you've made us all jealous. I imagine particularly those of our colleagues who are in Melbourne this evening. Our thoughts go out to all of you. We're going to be taking questions via the chat function on Zoom. So I'm sure everyone's familiar with this now. We've been doing it for many months. So please type in any questions you have in the chat, and we'll coordinate those to Melissa as we go over the next 15 minutes or so. Our first question via the chat, I'll read these out. So going back to your earlier statistics about the opioid epidemic, were your participants on medication? If so, how did you control for those effects?
Yes, so we did assess pain medications. So we assessed whether people were on opioids, and we assessed non-steroidal anti-inflammatory drugs and benzodiazepines, so those anxiolytics, and we essentially looked at those, but what we asked, one of the eligibility criteria for this current study was that people were stabilized on those medications and that they didn't change those medications. So people could continue treatment as usual, but as we were administering our RCT, we had people not start additional treatments. And so we tested to make sure that this was the case, actually making sure that there were not significant changes in those medications reported from pre-treatment to post-treatment, and there were not significant differences. So we didn't have to include that as a covariate, but we were looking at that. And certainly it's of interest. We're running another RCT in the States actually that's explicitly designed to decrease opioid use amongst people that have that are taking high levels that are at that at-risk dose. And so that's quite a different RCT design, but yeah, it's certainly of interest to see how our treatments can provide alternative pain coping techniques than just opioids.
Thank you. I should have mentioned before as well that the recording of Melissa's presentation will be made available, so we'll email that out and we'll have it up on the website in the next day or two. So if any of your colleagues weren't able to attend this evening, they'd like to review, or you'd like to go back over some of the data yourself, we'll get that out to you very shortly. Another question from Jason. Hi, Jason. Do you see any role for neurofeedback in treating chronic pain? That's providing people with direct feedback on their ongoing brain state.
Yes, we have run another RCT. There's only so much you can fit into 30 minutes. It sounds like a long time, but it's not. We have conducted another study, and this is very cool, and we're putting another grant to hope to build on this. But we were using neurofeedback actually to enhance theta prior to people receiving mindfulness meditation or hypnosis, because what we were finding, what our pilot data suggested, is that those people who had higher theta at baseline responded better to hypnosis and mindfulness. So we thought, well, let's take advantage of this synergistic effect. Let's kind of boost their brains on theta, then give them meditation or hypnosis so that we could get better effects. And we found that for hypnosis. And so we're building on that research, and I think it's very cool, this idea of preparatory interventions to really get people ready for the particular psychological treatment that is going to be of most benefit to them. So for some people, I think that's boosting theta prior to hypnosis, for example. Hypnosis has a tremendous amount of efficacy for pain management. For other people, we've found high levels of depression have actually predicted dropout in our trials, in our treatment protocols. And so that suggests the possibility there that the depression might have to be targeted prior to engagement in these skills building pain management techniques. So yes, I think there's a lot of exciting work that can be done in that space, including neurofeedback and potentially other preparatory interventions. Thank you.
Thanks, Melissa. And if anyone else has any questions, please feel free to put them through on this chat function. I've got a question, Melissa. I know a lot of the, well, there's a high prevalence of chronic pain among older people, and included in that group, people with cognitive decline and dementia. Have you or any others, any other research you're aware of, really looked at how to adapt and apply these psychological therapies to people with cognitive impairment or cognitive decline?
Yeah, that really is an excellent question, and it hasn't been really investigated very well in dementia. That's certainly an area that's in need of future research, where pain, that's a vulnerable group, and pain is not adequately managed there. The work of Dr. Beverly Thorne, I somewhat mentioned some of that in this talk, but her work is actually focused on reducing the cognitive load of cognitive behavioural therapy. And so that's so that people that have lower cognitive capacity, including cognitive decline, cognitive deficits can really still engage in CBT. And she has found that by shifting and adapting CBT, so reducing literacy, reducing cognitive load, giving people audio recordings to let them listen to some of the key points and teaching points from the session so that they can have, you know, reminders between sessions, that these types of adaptations have really been highly effective. And she's finished a large RCT that was recently published that identified that as effective. But certainly, yes, we need to do more within the area of aging and people with dementia. But in our RCT, I was a therapist for all of those treatments, and we had a gentleman who was in his mid-80s, and he got assigned to the mindfulness meditation condition, and he loved it. And him and his wife were both practicing meditation, so she started doing it as well. And I would give the reminder calls, you know, the night before treatment, and you know, they'd have the audio going in the background and they're both practicing meditation. So certainly even mindfulness can be, people who are in their 80s even can engage and get benefit from it.
Well, thank you. That's, yeah, that sounds like really interesting work as well. Another question from Kim about the effect of moderators, particularly interpersonal moderators, significant others, and the social context of the patients, the extent to which cognitive and behavioural change is reinforced by significant others.
Yeah, this is really an excellent question. And Kim, you retired too early. I was hoping that we might be able to do some of this work together, but certainly the social context, and if people are in a relationship, in a couple situation, those dynamics really do affect pain, they do affect coping, and it's really not well understood how that affects treatment. In the example I was just providing, that couple where they were practicing meditation together, it seems like it actually was something that helped them engage in treatment because it became an activity that they shared, and that happened quite a bit with other participants as well. But there's not been a lot of research. Anne-Marie Cano, Frank Keefe, there's a few people in the US that are doing more couples-based work because it recognises, yeah, that moderating role, that influence of that social dynamic, and certainly more work needs to be done in that space. We're also looking at even the social dynamic in our treatments. I didn't mention, but these treatments were group delivered, and just that social environment in that group delivery, that becomes an agent of change in and of itself too. And participants learn from each other, there's social learning going on from each other, and that bond that they form as well is really important. In our qualitative interviews, participants will, you know, often say that that group dynamic, those characteristics were really important to them because it made them feel not alone. Interestingly though, I've done qualitative interviews in my work in the US. It was so interesting reading the Australian qualitative interviews. It seems perhaps we're more direct because people here actually said, though, they spoke up and said, I did not like my group. I did not like that group member. And so it was really interesting to actually see some group dynamics don't help with treatment. And so I think there's really a need for future research to identify what are the optimal group dynamics. Is it people who are of the same age, of the same sex, the same race, education level, or is it that it's a mix? I'm not sure, but certainly that's a need for future research as well, given that group dynamics can help and potentially hinder outcomes.
Thank you, Melissa, and that's, there's some lovely stories there too. We have another question asking whether you could comment on the relevance of early experience of trauma in pain.
Yes, that is another particularly important topic. What we know is that people who have abuse at a young age or histories of traumatic experiences, sexual abuse, they are at higher risk for developing chronic pain later. Causality gets a bit tricky there. and it's not exactly clear that that past trauma causes chronic pain, but certainly there's an association and there's a correlation where those people tend to be at higher risk for conditions, particularly fibromyalgia and more widespread body pain. The actual mechanism, causal pathways, though, it's really difficult to identify those in that situation. You know, that's longitudinal tracking that's difficult research to do. But yes, those people are at high risk, but it's not clear why.
Well, thank you, Melissa. There are no more questions on the chat, and we're almost at time, so we might wrap it up there for the evening. But thank you once again for making the time, and thank you to everyone who came along and joined the presentation this evening. Again, this was a lecture given as part of the Paul Bourke Award that Melissa won last year, so congratulations again, Melissa, on that award. And I hope that others are able to get along to events during this Social Sciences Week 2020. Stay safe, everyone, and goodbye.
Thank you.